Well, welcome to this conversation, which will be of particular interest to patients with a chronic cough like me. I'm Jane Calvert-Lee, and I'm a patient member of the NeuroCough patient group. This group is made up of clinicians, researchers, academics, industrial partners like pharmaceutical companies, and of course, patients. And the aim of this group is to facilitate and bring together all the people that are involved in chronic cough, research, treatments, which will be of benefit long term. I'm delighted to have this afternoon Dr. Peter Kardos, who chairs the NeuroCough patient group. Dr. Kardos is based in Frankfurt, Germany, and has spent his career specializing in respiratory, sleep, and chronic cough conditions. So what better speaker can we possibly have? Peter attended the annual International Congress of the European Respiratory Society held in Milan in September. So Peter, please introduce yourself and tell us, what did you come away with from the Congress, which would be of interest to patients with chronic cough?
Hi, Jane. Thank you very much for this introduction. I would like to start with a magic number. And this magic number is 170. 170 cough-related sessions, presentations, abstract sessions, e-poster sessions were presented in Milan at the ERS International Congress. And this is a revolution. Never before we had such a high number of presentations on cough, and it should give hope for the patient that after decades of ignorance, now cough is coming in the focus of research, and we will have new results in a few years, which can help patients very well.
Well, I think there's some treatments that are offering a lot of hope to patients, such as gefapixant and camlipixant. Was that discussed?
I would like to summarize the available treatments. None of them is approved, and none of them is a general effective treatment. Imran Satia from the McMaster University in Canada summarized very nice the available treatment options. And this is the speech therapy, which is very effective, not only, but mostly in upper airways cough syndrome, if you have a larynx hypersensitivity, if you have a problem with your sinuses, chronic sinusitis, and so on. You can learn cough suppression. The problem with this treatment is that you need a well-skilled therapist, and this is not everywhere available around the corner. I used to say the next one for us in Frankfurt is in Sydney in Australia, but it is probably we get more and more possibilities. Then the second one is low-dose morphine retard capsule, which is proven in a study, and it was efficacious probably in 20 to 25% of the patients in a low dose without severe side effects, but even the majority will not benefit from this treatment. And then we have the three so-called neuromodulators, because we think that chronic cough is a problem of the nerves innerving the cough receptors, and you can use pregabalin, gabapentin, and amitriptyline, which is on the market, not approved for this indication, but again, 25% of all patients will benefit from. Then the first important and new study was shown, and this is a repurposed drug. Repurposed drug does mean it is a drug which is since decades on the market and which will be used for treatment of opiate dependency, This is nalbuphine tablets. It is available as IV in Germany as well. And these tablets were given for patients not with the classical chronic cough, but with chronic cough in idiopathic pulmonary fibrosis. And cough in fibrosis is a huge medical problem with unmet needs, and the drug was very effective. This is probably the most promising one for a patient with idiopathic pulmonary fibrosis. And then we got a overview of drugs which are now in development, and these drugs will come on the market. It is now phase 1, phase 2, not before 2028, 29, or 30. These are neurokinin antagonists and MNDA antagonists, and then sodium channel blockers and menthol receptor agonists, which are very effective in the first trials, because the cough receptors have a lot of different receptors. And what you ask just about gefapixant and camlipixant, this is a P2X3 receptor antagonist. Gefapixant is approved in Germany and in Switzerland, but not available yet. And it is available in Japan at least 1 year, if not more. So we have more and more information on practical use. And the last one, what I will mention, is camlipixant. It is now in phase 3 trials. If you look the gefapixant efficacy trials, you will see that there is a reduction in cough frequency about 15 to 20%, and this is a relatively weak result. However, this is above placebo, and placebo effect in this trial was very high. The placebo effect is a very well-known and important effect. If you have, for example, an asthma, and you give a spray which is effective, and you can inhale the spray, you can measure your lung function, and the lung function will improve. And if you ask the patient will say, "Oh, now I can breathe much better." The problem is, if you give a placebo spray, placebo does mean that this spray is similar like the original spray, but without effective medicine in it. And it looks like the other one, and the patient will inhale it, and the patient will say, "Oh, now I can breathe a little bit better." And this is a placebo effect. Because if you measure the lung function, there is no improvement. But the patient-related outcomes, especially cough, quality of life, and so is very sensitive for placebo. And so there is a placebo effect. And if you have an effective drug, the drug should be even more effective than the placebo. I can't prescribe placebo to a patient. I prescribe only the drug. And if I prescribe the drug, which is 20% more effective than placebo altogether, I get a reduction of cough frequency in 45 to 50% of the cases. This will help patients very well, and not only the cough frequency, but also the cough severity, and the quality of life is reduced. The problem is the side effect. This is makes the drug a taste disturbance, and many patients stop taking the drug. Next day they can taste again well, but the cough is coming back. Camlipixant, the next one, is more selective and doesn't influence the taste receptors. So we have no problem with disturbances of the taste, no more than placebo. And we learned in the gefapixant trials that these drugs are more effective the higher, the more severe the cough is. And in the very severe coughers, you have efficacy far over 50%, 70% of the cough severity. And there is a remarkable improvement in the quality of life. What we think, if it is achieved, then the patient will feel he's better. It is 3 times more improvement in quality of life.
Peter, that is really encouraging news. Not all countries have cough clinics, not all cities have cough clinics. How likely are patients who aren't based, say, in big cities where there isn't a cough clinic likely to be able to access any of these treatments? Will their local doctor, their local GP, general practitioner, know about these developments?
I think this is a very important question, but it is also valid for even for the diagnosis of chronic cough. And we have to promote lectures, presentations on conferences, not only on special conferences like ERS in Milan or ATS next year in next May in San Diego, but also for general physicians to make the drug popular. And chronic cough patients are looking on Google what is available, what they can do. It is not bad if the patient already knows that there is a drug and going to his family physicians or to his specialists and told, I saw on Google that this drug is now available. Can I have this? It is for my cough. It is good or not? I think it will be a good promotion if the drug is once available in the pharmacy. Now, at the moment, there is no promotion at all beyond special conferences.
Well, I think it's all the more reason why we should encourage patients to look at the NeuroCough website, because that is where they will get the latest information. I'm always worried about information you get from Google, whereas NeuroCough is, made up of clinicians and academics and researchers who will make sure that the information that it provides is accurate and reliable. And also, I want to stress that the NeuroCough has developed a registry of patients willing to take part in clinical trials. I've taken part in a number of trials, and they're really useful because they are the means by which we're going to get these drugs online. So please let us encourage all cough sufferers to put their name forward to participate in these clinical trials.
May I support, first of all, your statement. NeuroCough is a very important initiative, and every cough patient should see the website. And if we are speaking now together, this is also a NeuroCough initiative of the ELF, the European Lung Foundation.
A lot of patients go to the doctors with their symptoms and they're assessed to have asthma. I had a great battle with my doctors to say that it wasn't asthma. I had something other than asthma. So I think we need to educate some of the doctors as they're coming on stream that there is this condition known as chronic cough, which is slightly different from asthma.
I think the expression chronic cough is not a very good one. And in Germany, I don't use it because chronic cough doesn't mean more than the patient is coughing 8 weeks and more. And we speak about what you have, and we speak about now, this is chronic cough, not as a symptom of tuberculosis, of lung cancer, of interstitial lung diseases or asthma. this is an illness on its own. This is not a symptom, it is an illness. And if you want to have a comparison, an asthmatic patient has often breathlessness. But breathlessness is not an illness. Breathlessness is a symptom of asthma. And in this case, it is not so. It is an illness, chronic cough, refractory chronic cough called RCC on its own. And even an asthma patient can have cough. And if you treat the asthma, the cough is gone, then it is not a problem. This is not refractory, but it is not wrong if a doctor is thinking about possible causes of chronic cough, like asthma, like COPD, like interstitial lung disease, upper airways cough syndrome, or there are very popular treatments, ACE inhibitors for hypertension causing chronic cough as well. This is important. This should be excluded. And then the remaining patients are the RCC or UCC.
Thank you. I think that's extremely clear. And I think lots of patients will welcome that sort of clarification. Well, thank you very much, Peter. Were you encouraged overall by what you heard at the Congress? Do you think that there is a greater appetite by the pharmaceutical companies to pursue treatments for chronic cough, and a greater understanding in the medical profession of what a chronic cough means to patients?
I am sure this is the case, and I started, there is a revolution now, and never been chronic cough as important, as much research, and it is now. So cough is coming up.
So thank you very much indeed, Peter. That's been really useful conversation. And I think many of patients will be encouraged by what you've reported back on. Thank you.
I hope so. Thank you very much.
Have a good day. Bye-bye.
Thank you. Bye-bye.